started with the ACS NSQIP program in mid-2007. And at the time, we had a very robust surgical performance improvement committee. However, we were looking at the core measures from Medicare, and those were process measures. We really wanted to scrutinize our outcomes. And the ACS NSQIP provided data on outcomes which were risk-adjusted, they were evidence-based, and so that was a perfect fit for us to improve looking at those outcomes. Well, it really didn't take long. Within the first year, we had acquired approximately 1,400 patients in our database. And what we found was that we were a high outlier in catheter-associated urinary tract infections. And so at that time, we became very concerned. We thought, wow, patients, they don't want to come into the hospital and get a hospital-acquired infection. We didn't know how we were doing, and NSQIP provided us with the details about those infections. The first steps were drilling down, looking at the data. We pulled those cases and we scrutinized that data, and we found that a couple things. We had some issues with unnecessary placement of indwelling urinary catheters. Our aseptic management or technique was probably not as good as it should have been. And then Foley catheters were really being left in the patient way too long. And then we used the ACS NSQIP best practice guidelines, which was very helpful because the ACS provides clinical topics where you can improve based on things like thromboembolic events, pneumonia, and what we used was the catheter-associated urinary tract infection. These best practice guidelines are actually based on evidence provided by the CDC, by the IHI, and so we actually just used that to formulate our own protocol. But by 2010, we had a significant reduction from a rate of 2.6% UTI risk in 2008 down to 1.5%. And that was looking at another 2,400 patients which were captured within our database. This was a 62% reduction in catheter-associated urinary tract infections within our hospital.